So welcome everyone. Today we are very happy to have a guest speaker for the endocrinology grand rounds. Today we have Dr. Maria Fleseriu, who is from the Pituitary Center at Oregon Health Sciences University in Portland, Oregon. Dr. Fleseriu is currently professor of medicine and neurological surgery at Oregon Health Sciences University, and has served as the director of the Pituitary Center since 2007. For those of us interested in pituitary disease, we are very familiar with her work. She is widely known and has been a guest speaker both nationally and internationally at several conferences. She is the deputy editor for the European Journal of Endocrinology, associate editor for reviews of endocrinology and metabolism, and has been a member of editorial boards of many endocrine journals, including Pituitary. She has been a principal investigator on pituitary disorders in clinical trials, has over 250 publications in high-impact journals, and she is one of the authors of the consensus papers on Cushing's disease, acromegaly, and hypopituitarism. She has been the past president of the Pituitary Society and served as a member of the executive board of the Pituitary Society. And she's a member of the board of directors of the Endocrine Society. She has received numerous awards, both national and international, including the title of Doctor's Honoris Causa by the University of Medicine and Pharmacy, Carol Davila, and the Clinical Endocrinology Trust Award from the UK Society of Endocrinology. So we're very happy to have her talk today about management of Cushing's disease, striving for personalized care.
Thank you so much for this nice introduction. And if you have any questions in between, because I can't see on Teams everybody, you can just stop me and I can answer. If not, I will leave some time at the end. So hopefully you can see my slides. These are the disclosure related to Cushing's. The scientific consultant is personal and the grant recipient goes to the university for the clinical trials, and the consultancy is related to being either in the scientific committee or advisory boards for particular trials. So as you've seen from, it's hard to talk about Cushing's, and we're chatting earlier that the advancement for the last 10 years in pituitary disorders are huge, and I'm very pleased. But that makes our life more complicated for this particular talk, because I'm not going to be able to share with you everything that's new in 45 to 50 minutes. So I decided to describe for you the changes in the landscape, so how many new medications we have. And then to talk a little bit about complications that we all encounter seeing patients, and then to discuss a little bit more about individualized medical therapy and striving for this. And of course, I'm not going to talk about insurances and how they are not helping us with using individualized therapy. So when we're talking about the epidemiology of Cushing syndrome, what is new there? We recently looked for this JAMA review. Are there any changes with what we used to think? And it's no clear data in endogenous Cushing syndrome incidence or prevalence, and just because especially we don't have data in US. However, it seems that the adrenal Cushing's is becoming more frequent, and probably we test more for incidentaloma. That's a completely different talk. And then the differences between Cushing's disease and ectopic Cushing syndrome are related to the type of diagnosis. So we do petrosal sinus sampling in more patients and so on. So now it's more clear than some ectopic disease will actually in initial studies will look like it's Cushing's disease. So the percentages are changing all the time. So for the fellows on the boards, you are still going to have about 60 to 64% Cushing's disease, then 6 to 10, that depends how you count the ectopic Cushing's, and the rest are adrenal overall. And because of the Cushing's disease, it's predominantly women, overall is 3 to 1 female to male. Now, why is it important to talk about Cushing's? Because it's my favorite disease, but that's a different story. But also, Cushing syndrome is associated with both increased morbidity and mortality. And we have heard this for many, many years. In the initial studies 50 years ago, the mortality was 4 times elevated. So we thought that over the years, because we have much better treatment, surgery, radiation, and all that, and we can put the patients in remission, things are changing. However, if you're looking, this is a meta-analysis coming from UK that's relatively recent. Still, the standard mortality ratio was overall 3. So this is very high. And if you're looking now in Cushing's disease versus adrenal Cushing's, and this is without cancer, still it's very high. Of course, active and remission, but remission didn't really normalize either. And for microadenoma was also higher, so it's not related to the tumor size overall. And then, of course, for adrenal, both adrenal adenoma and bilateral adrenal hyperplasia. So when we saw this data presented, we're like, this is impossible, still now to be so high. And when you look over the years, it was some decrease. However, because of the atherosclerotic cardiovascular disease, infection, cerebrovascular disease, and malignancy, because the patients live a little bit longer, so at least that, we still see high mortality. So we should do a much better job in both treating the Cushing's. But I think, as you see here, from infections to cardiovascular disorders and hypercoagulability plays a significant role. See here, 4.4. We should probably change our paradigm in how we address the comorbidities also. So where we are, and we briefly chatted about this before we even started. So this is all these advances in the medical treatment are for the last 10 to 12 years. But if we're looking at when we started with what Cushing's is from Harvey Cushing's, now we're more than 100 years. And then some advancement with surgeries, and then no approved medications in US or anywhere in the world for that matter until mifepristone in 2012, pasireotide the same years. Then these metirapone and keto were approved in Europe, but not in US. And then osilotrostat was approved in US, and then levoketoconazole was approved. So where are we now in this year? Hopefully I can advance. Are we making progresses overall? So we'll start with the ectopic Cushing's because that's a little bit easier. Because if we find the tumor, well, I'm not going to talk about diagnosis unless you have questions at the end. But for ectopic Cushing's, if we see evidence of tumor, then tumor and lymph node resections are next. And with resection, if the tumors are smaller, then the patients will achieve remission, and the rates of recurrences are much lower compared with Cushing's disease, and I'm going to talk later about that. And if not, we talk about medical therapy later. And there are some advances also in the radiotherapy with peptide nucleotide therapy that has been approved. And then, of course, for very, very sick patients, we still have to do bilateral adrenalectomy, though we are using more and more medications for that. The Cushing's disease picture, though, it's much more complicated, and we have reviewed this recently with several case-based reviews for Nature Endocrinology, and looking in what do we do for patients that have Cushing's disease. If they are candidate for surgery, then it's relatively easy. We consider preoperative medical therapy if the surgery is delayed, and I can talk to you a little bit more about that when I do it, and COVID changed my perspective. And then definitely, if I can do surgery faster or send the patient to surgery, I actually don't do it, then this is probably the best treatment, keeping in mind that we have to treat the comorbidities in the same time. And if it's a small tumor with a good surgeon, I tell patients you have a higher likelihood of remission. I try not to use the word cure, no matter how much they push me. And also, we learn over the years, and I'm sure this is your experience too, that checking the patients, they actually recur way more than we thought. I used to tell patients 10 years ago or 15 maybe, that if you are in adrenal insufficiency for a long time after surgery, you are fine, you're good to go. Now, the more we're following these patients, and I'm in this center for more than 17 years, so I end up seeing these patients all the time. We find out that I had the recurrence at 17 years. The patient was seen even before I was here at 20. So they have to be followed forever. And then, yes, we have some predictive factors for recurrence, but everybody can recur. And of course, we tell from the beginning, so to set up the expectations that if you have lower likelihood of remission, yes, you need to go to surgery, but I will really start medical therapy planning and approval before. Now, if the patient is not a candidate for surgery, then usually I use medical therapy. Rare, I use radiation without for Cushing's disease. For ectopic, it's a different story, without having surgery, unless there are really contraindications, and then continue medical therapy. What is very important, and before I'm talking to you about all the drugs we have available, I wanted to discuss with you the paradigm about, yes, we're using medication. We can't really use the cure even after medications. If they are normalized, I would say remission on medical therapy. But it's actually balance if we follow the patients long enough, especially, for example, for peripheral targeting therapy. We use medical therapy, but we shouldn't start a medication and then leave the patient on that, because sometimes they have either poor response or intolerance. And I send them sometimes, if they don't do that, to repeat surgery. Then, of course, sometimes patients have radiation and they need bridge medical therapy. So we need to stop the medications to see how the patients are doing. I do usually do between 6 months and once a year. That depends. Of course, much rare, I use now bilateral enterectomy because we have all these medications available. And then with all medications, but especially with peripheral targeting, we need also to monitor for corticotroph tumor progression. I have several patients now that are doing great biochemically, but the tumor is either growing or not decreasing, and they start to have issues related to the tumor itself. And of course, as I said earlier, always monitor for recurrence, even if we think that they are in remission. So when we're talking about medical therapy, several of you are very familiar because you're prescribing these drugs all the time. But for those of you that are endocrinologists not working with Cushing's all the time, we have now many, many drugs approved, and you see them here in green with a checkbox green if they're approved in US. And the really mainstay of therapy now are the adrenal steroidogenesis inhibitors. And we have 2, and I will talk in details, approved in US. And then we have pituitary directed agents. And when to use one versus the other, that's when it's the art of medicine. And then, of course, some predictive factors, and then glucocorticoid receptor blocker that's approved for hyperglycemia associated with Cushing's. So when we talked on the consensus meeting of how to describe the response to therapy, and I will have some other criteria in the end, but for now, when I'm showing you the data for each of the drugs, I want you to think that when we describe remission to medical therapy, it's not really the same for everybody. So some patients are fully controlled, some patients are partially controlled. Now, what do you mean by partial control? Some of you can ask me, is a combination between clinical and biochemical factors. And of course, no control, it's easy. The urinary free cortisol is high, the patients have a lot of comorbidities and they don't feel well. So no control versus control, it's easier. The partial control, I will show you some data that we still have trouble. And of course, combination therapy, sometimes though significantly less than acromegaly, is used right now. So adrenal steroidogenesis inhibitors, as I said, they are the mainstay of therapy, and we have 2 FDA approved, and the others were using them off-label, and I'm sure you do that too. So the levoketoconazole, we did several studies. I'm going to show you briefly data from few of them. So Sonics was an open-label international study, and if we look, most of the patients were Cushing's disease, 87%. And what was interesting is, because it was done also in Europe, 30% of patients did not even have surgery. So these were patients, a lot of them naive to any type of therapy. So for looking at the response rate was 31% at 6 months and 41% of 12 months. However, when we looked at clinical signs and symptoms, you can see clearly the acne global score, the hirsutism in females, the peripheral edema, and then other clinical signs and symptoms and quality of life improved. So it's important when we're thinking about which medications to choose to also look at clinical characteristics. The most frequent AEs were nausea, hypokalemia, and headaches. Keep in mind, similar to ketoconazole, you can see with levoketoconazole abnormalities in liver function, and the reversible QT prolongation was about 10%. For the next study, this was a randomized withdrawal study. So patients were treated, all of them, with drug, and then for one group, they were continued on placebo, and one group continued on levokitoconazole. So if we look at the treatment difference, was clearly significant. And you probably are familiar with the design of placebo now, because FDA is requiring both for Cushing's and for acromegaly. And I actually like it for short term, unless the patients will develop complications and then we treat them immediately, because it gives us an idea also about the natural history of several of the symptoms, because not everything is improving or not everything is worsening. So most clinical signs improved during the study when the patients were on drug, and then definitely in the randomized withdrawal phase, the cholesterol and some other factors also change. Otherwise, probably we need much more time. Keep in mind that FDA has 2 warnings for this medication, both for QT and LFTs elevation. So when we use it, we have to make sure that we have serial labs, and I usually perform EKG at the beginning and then after starting the drug to have them there. And then closely monitoring for adrenal insufficiency. You're going to see this for all the drugs, because that's as much as important as to check for Cushing's if the patient is on remission. The second drug that I'm going to show you that we have significantly more data because we just did more studies. I'm not going to show you all the results for short term, but this was similar with what you've seen before, but the placebo was at the beginning. So this was a placebo-controlled period, recently published in GCM. And if you can look at the patients that were on osilodrostat versus placebo, also a significant difference that we expected. Reductions in UFC were clearly accompanied by improvements in cardiovascular disease, quality of life, and overall well tolerated compared with what we think in Cushing's. Almost everybody has some symptoms related to withdrawal also, but the hypocortisolism related events were mild and moderate, but were seen in a lot of patients. And I'm going to show you a little bit more data later because this is important from clinical point of view. So if we're looking at efficacy rates, and I'm not going to show you all these studies because it's the end of the day for you. That depends on the design of the study, but this is a very potent drug. And as you can see, from 68 to 81 to 78.9, so very potent drug. What's important, and these are 2 studies that we have published now, it's not last year anymore because we're 2024, but on the left, you have a very small study that we started long time ago that we have the patients followed for. Median was to 82 weeks, as you can see, and some of them were for more than 6 years. The UFC goes down and stays, and some of the labs at the beginning were very high because these were initial studies. And then the one that's even more important, and I wanted you to look in detail, was just because it's the magnitude of the study. So this was LINKS 3. This is published for who wants to see more data in the European Journal in 2022. There were 160 patients continuing the extension. This is where they started in the mean one, and then this is the extension study. And if you're looking at exposure, was over 130 weeks. So this was significantly longer that we like to see for patients treated with medication. And what was important, and I would be happy to share with you more data, but briefly, the dose was decreased over time. So that's important again in clinical because we start with higher doses and then at some point the patients might require less. And then I tell patients that if they ask, do I have to be on this drug for long term? The answer is probably, unless we get another treatment. And then I tell them that long term, it's about 80% that will respond. So it's still not 100%, but it's pretty high overall. I told you earlier that the rates of hypocortisolism-related events with osilodrostat are pretty high. And this is an oral presentation that I had now many years ago, and then the data is split in between several publications. But what's important from clinical point of view, because the data I'm going to show you throughout, I chose from all the studies what could be clinically relevant, is the dose titration schedule. So in one of the studies, the LINKS 3, everybody was titrated very fast. And then in LINK 4, that was a little bit later, it was titrated every 3 weeks. So 1 week every titration makes a difference. And also the higher dose was a little bit lower. So if you can see, the proportion of adrenal insufficiency was clearly less if the titration, and This is not all of it adrenal insufficiency. Some of it is withdrawal, but from clinical point of view, sometimes you don't know. So from clinical point of view, osilodrostat, I always start at low dose. Most of the time for mild Cushing's, I start at lower than approved doses and then go up on the dose as needed. And then definitely monitor for adrenal insufficiency. It's very important, even more important than for other drugs, just because the drug is potent, hyperkalemia, and then pituitary tumor changes in Cushing's disease, that it's important for all the drugs that are working at the adrenal level, blocking or glucocorticoid receptors, but for potent drugs might be even more important, that we didn't see huge differences long term. And just as a reminder that there are some other adrenal-directed agents that some of us are still using. Ketoconazole, metirapone are not approved. And then mitotane, I have not used it for anything else besides adrenal cancer. It's approved for that. However, in friends, for example, are sometimes using it even for Cushing's disease, but I have no experience besides adrenal cancer. And then I use some of these drugs because they're off-label. They don't have warnings on combination when we need, but this is a CME, and I want you to remember everything between these drugs and then also the combination of the drugs is off-label overall. So briefly, I wanted to remind you about etomidate. This is the only intravenous therapy available for Cushing's. Now, I have to say that I'm using it less and less because the osilodrostat is so potent that we're able to use it even in very severe patients, and I do block and replace. However, if the osilodrostat is not available, everybody has etomidate. Also, I go with block and replace. The problem is because of the sedation, the patients need to be in ICU, and none of the hospital administration likes me to use ICU beds for that. So just as an idea that potentially we have some drugs if we want to quickly block it before, but this is the one I use usually before adrenalectomy. So let's switch to pituitary-directed agents. These are drugs that work at the pituitary level. And what I would like to see, I would like to see more potent drugs, talking about the future, that are controlling the cortisol better by working at the pituitary level. So at the beginning, we thought that this would be pasireotide because the in vivo studies look great. As you see, compared with the octreotide, had significantly more potency at receptors type 5. So we were hoping that this would be able to control the ACTH enough from the tumor that also will control the cortisol. Now, there are several studies. I'm just summarizing for you most of them, both for sub-Q and for LAR, which is once a month and in a different dosing than approved for acromegaly. So when you're looking at that, especially for the fellows, the doses are different. But the control rate, it's really 50% in mild Cushing's, and in severe Cushing's, it's even lower. And the side effects are also some related to GI that were expected because we all use octreotide for a while, but the hyperglycemia is very frequent. And we know now, and some of you that are working in the diabetes world know even more about that, that in addition to the secretion of insulin that the pasireotide inhibits, also inhibits release of GLP-1 and GAP and decrease glucagon. So this is really problematic for patients with Cushing's that have some disorders to begin with. So for mild Cushing's, as I mentioned earlier, as you can see, it's about 50%, but look at the rates of hyperglycemia. So in some patients, they were 80% that had at least one hyperglycemia event. So definitely I'm using it in patients that have very large tumor, failed several surgery, but this is not the first drug I would start with. What was interesting from the studies, and I'm not going to show you all of that, when we looked at this, and this was led by Newell Price, the clinical improvements for patients, just look at the blue. This is patients that had both urine and saliva cortisol, and we're working on that now for the other drugs also. Look at the clinical improvement if they had both control in blue. This is systolic blood pressure, diastolic blood pressure, this is weight. So definitely the endpoint of the study was normal UFC for all the studies you've seen until now, but probably we should look at more markers because clearly the patients are doing, very few patients had control both, as you can see, but we need to think more for the design of the future studies and in clinic. The advantage of pasireotide is tumor shrinkage. or at least no tumor growing. As you can see, this was a patient that didn't have surgery, and then look here, the tumor shrank significantly in 12 months. This was published a while ago. And if we look at meta-analysis that was now 2 years ago, very few patients had tumor seen, and especially macros, because most of the Cushing's is micro disease. And you can see, yes, potentially plays a role. But so in my mind, I look at this as if the patient has a large tumor, then it would be a drug that I will start versus adrenal steroidenase inhibitors, and then decide if the patient responds. If the patient doesn't respond or develops severe diabetes, then I switch and change my mind after that. How about glucocorticoid receptor blockers? So this is approved for patients with hyperglycemia of all causes of Cushing's. And I don't have recent data to show you. So as you remember, this was the first drug approved. We did a study and published in 2012. So that's now more than 12 years ago. There were a few patients in phase 3. We used several doses. Most of the patients ended up being on the highest one, 1200. Improvement in glucose and clinical signs and symptoms. Adrenal insufficiency, and remember, you can measure cortisol. Hypokalemia could be severe if we don't replace well. I usually do spironolactone to begin with. And then, interestingly, thyroid function needs close monitoring, not just in patients with primary, but also in patients with central hypothyroidism. And we don't really know the full mechanism, and does not control the tumor volume. And as you remember, the improvement in diabetes, and this is why it's approved for that, look at this A1C, and the area under the curve for glucose was the same. And this was despite changing some medication. So clinical improvements were a little bit more murky. If you look here in red, you see that some patients improved significantly, but also some patients didn't see any change. So again, this is trial and error. And that's why once we start a drug, we should make sure that the patients will continue the drug or one of the drugs if it's really working for them, both clinically and biochemically. In this particular drug, it's more clinically because we don't have anything else. So very, very briefly, what else is new in medications before we move to the complications. This is a partial list. It's not everything, but completed phase 2 trial. It's relacorilant, a new glucocorticoid receptor blocker with no progesterone effect. So this wouldn't have anything with vaginal bleeding and abortion and all that. So this would be important. Then roscovitin, it was published a small trial. It's a selective cyclin-dependent kinase inhibitors. I have to say, I was hoping for significantly more improvement at UFC. It was a small study, but still, we don't have good drugs working at the pituitary level yet. Phase 2, it's in progress. SPI62, it's an 11-beta-hydroxysteroid dehydrogenase type 1 inhibitors. You've seen some data on osteoporosis and others, but we don't have anything in Cushing's yet, and particularly from this study. And then it's a phase 1 in healthy volunteer with a drug from Crinetics that's an oral selective ACTH antagonist. Again, we don't have too much data about that. That's public. But the idea is we are moving forward with other options. So it's even more important to really know all the data from the studies, but also which drug is better and for which patients. So which are the considerations when selecting or switching? So I briefly touch at each of the drugs, but this is a summary of what I have in mind when I talk to the patients. So severity or other physicians that are contacting me. Severity of hypercortisolism or tumor characteristics are important. Not as important as in acromegaly because we don't know enough about it, but I'm sure there are some. We hoped at some point that USP mutation is going to really either 8 or 48. Tell us which drug to use. Not really. We need more progress there. How potent is a drug? So I tell patients, it doesn't mean that if it's 80%, you are going to be that one, but we know from the beginning it might respond more than others. And then medical history, sex, different effects on estrogen, concomitant medications I didn't show you, but all the drugs have extensive lists of drug-drug interaction, especially mifepristone and levoconazole, but osilodrostat has some too. And of course, patient preference. Some want an injection once a month. Some want a drug just to be oral, even if they're taking it twice a day and so on. So how do we monitor response to therapy? It's a combination of clinical endpoints, and this include everything. Now, if you're asking me, how do we do this in a short visit when the patients are coming and we have to refill medications and talk to them about everything? That's the complicated picture in US. But we're trying to do serial visits especially when we're assessing clinical endpoints, and we do some in clinic and some we do virtual after that, just to get everything done, because otherwise we'll need a full day visit just for that. And then, of course, for glucocorticoid receptor blockers, we can't use cortisol. The cortisol concentrations, if you're asking me how do we measure success, we still do urinary-free cortisol, though I'm not a fan of, because we don't have any good data in where we want, especially for adrenal steroidogenesis inhibitor, and we're working on more analysis right now for the late-night salivary cortisol. But this is from the guidelines, and the reason we put that is that the urinary-free cortisol is sometimes used, especially from these studies, also as a marker for adrenal insufficiency. We should not do that, because the morning serum cortisol is the one that actually can tell us. And there are some issues with that, especially if the labs are not using LCMS. With adrenal steroidogenesis inhibitors, remember that you can be falsely normal, and actually the patient has adrenal insufficiency. And then change in treatment is very important. I showed you before, if the patient does not respond, for pasireotide, we know in 2 months, for other drugs even earlier, change the drug or the combination. Just leaving the patient better than started but not normal is not good for long-term outcomes. So how about complications? I'm done with treatment, though a lot of the complications I'm going to talk to you about also go back to we should probably treat the patient for Cushing's, but also the comorbidities in the same time. So we know a little bit more now about cognitive impairment in Cushing's, and what I tell the patients, I'm not going to have time to discuss about all of them in detail with you, but I tell the patients that cognitive impairment is seen. I send them sometimes to occupational therapy. The withdrawal makes things even more complicated, and unfortunately, in combination with the neuropsychiatric dysfunction that these patients have, this is the main cause that the quality of life, if you look at all the studies, and I'm sure in your experience, does not return to normal. Patients with most pituitary disorders have some changes in quality of life, but most of them at least significantly improve or return to normal, but that's not the case for Cushing's. Now, musculoskeletal disorders. We knew about osteoporosis for a long time, same with fractures. However, the myopathy, we thought that this is improving much faster. So now with longer term study, we see that it's still persistent, even with stent and rising test for a long time. And there were some studies from Germany looking at growth hormone deficiency and persistence of myopathy. So it's linked definitely, and I'm not showing you this data now, but it's linked definitely with a curve for the IGF-1. However, we have no clear data that myopathy is improving if we treat the growth hormone. There are other reasons for adiposity and the neuropsychiatric issues that we should treat patients with growth hormone deficiency and Cushing's, but that's not for myopathy per se. And then the metabolic disorders, they're very, very frequent. And I just showed you that for some patients, the treatment that we're using to treat their Cushing's might make things worse. So it's very important, and the same thing with this lipidemia, to know in advance where we start, and also if the patient has severe diabetes, to go with which drug versus the other drug. And then immunodeficiency, that became very, very important for infections, and especially we lost, unfortunately, several patients with Cushing's, with very severe Cushing's when they got COVID, especially the one that they were not vaccinated. It was tragic to all of us. But yes, severe Cushing's is really inducing immunodeficiency, as you all know. And then I left it at the end because I'm going to talk later about it, but also, as you've seen, is the main cause of mortality. So cardiovascular and thromboembolic disorders. We knew about cardiovascular disease and, of course, hypertension and stroke, but the risk of hypercoagulability is significantly higher than we used to think even 10 years ago. So we did this meta-analysis now many years ago, and we looked at, it was not really a lot of data, were 48 studies, and 3% of patients experience VTE. So we're like, okay, that's probably a low percentage. But then when we looked at control groups, general population, or the hip fracture surgery that I came up with just because I remember that we had to anticoagulate everybody for hip. I could have chosen knee because now they're doing the knee, and in between I also had the knee surgery. But overall, if we're looking at the odds ratio compared with the general population, was almost 18 times higher. And it was a little bit lower versus hip fracture surgery. But keep in mind there, they anticoagulate everybody. And in Cushing's, we do not. So this is something to keep in mind. So when we looked at the guidelines, and it was an international consensus, very hard to say because every country is doing it differently, as you know. We decided to say should be considered because, again, this is a very individualized treatment, risk, and also benefits. So discussion with if the patient have history of embolism or abnormal coagulation, severe disease, current use of estrogen that usually I'm trying to stop, perioperatively, extended preoperative or postoperative stay, and then high post-op cortisol if they're not in remission. I usually recommend anticoagulation unless they have clear-cut contraindications. And we restart post-op. Now that depends. The ENT surgeons will like us to wait a little bit more. But even if the patient is remission, you know that the inflammation will actually increase because the cortisol goes down. So it's very interesting, but there are more events immediately post-op. And I'm not going to show you all this data, but we have published and looked at our data. And of course, everything we can do in addition to anticoagulation, early post-op ambulation, compression device, and so on. How long to continue? We could not find a consensus. And the reason is that there are data, including ours, that especially after BLA, there were events even after 2 months. So for BLA, I continue for 2 months. For all the others, who knows? I'm trying to stop at least at 1 month, but do I do the right thing? We don't really know. So there are other things that we have reviewed now 2 years ago in the perioperative management of a patient with Cushing's disease. I'm not going to talk about all the details because I wanted to leave more time for questions, but I wanted to briefly show you how we think about for a patient that goes to surgery. So this is patient we already selected that needs surgery. We do sometimes preoperative medical therapy. We did it more for COVID times now. Again, it's coming back, so we have to delay some of the surgeries. But then the management and prevention of comorbidities is as important as the treatment for Cushing's. And I think that's one of the reasons that from cardiovascular, thromboembolic, infectious, sometimes we send them to cardiologists even in the same time and all that to try to catch up because the mortality is due to these factors and it's not enough. If the patient had Cushing's for 10 years, I'm sure fixing the cortisol in 1 day doesn't make a huge difference versus waiting another few days. And then I'm not going to go in detail how we assess for remission. I would be happy to answer, or you can look at this paper. Then the glucocorticoid replacement type. It's very important decision because we have to make sure that the patient doesn't develop adrenal insufficiency, but also to go with them through the withdrawal. Because if we continue long-term, usually I discharge them on higher doses, but then if we continue long-term, very high doses, then the patient will never go down to lower doses. However, the opposite is true. And I tell them, my job is to make you miserable, and I'm joking with them. I want you to be unhappy that you are decreasing the hydrocortisone dose, but also being able to function with the withdrawal symptoms you have. So it's always a balance. And then keep in mind that especially for patients that had repeat surgeries or extensive surgery, that for Cushing's it's even more, we see risk of both SIADH and diabetes insipidus, that now it's not called diabetes insipidus anymore, but the paper was published before. It's called APP deficiency. And it's important even when we do the withdrawal in the hospital. So we don't give them any steroids, and then the patients will not be in AVP deficiency because they also have adrenal insufficiency in the same time. When you give them back the steroids, they start peeing like crazy. So is this just fluid excretion versus true AVP deficiency? And this is a fine mechanism. The thyroid needs to be rechecked within few weeks because it was usually low before and all that. So there are a lot of things we should look and think about when we treat patients with Cushing's, in addition to the treatment for Cushing's per se, that I focused on medications today in the interest of time. So which patients can we consider for medical therapy? In my view, I'm using medical therapy for Cushing's disease, for ectopic, and for adrenal Cushing's also. I didn't focus too much on the adrenal Cushing's because usually we send them to surgery, but if they have bilateral adrenal disease, I usually, if one of the gland is larger, I send them to surgery to take that one. Usually the disease recurs in few years and we use medical therapy. In older patients with bilateral adrenal disease, I use low dose of medical therapy and they're doing great if they have comorbidities. I'm trying not to treat just numbers. For persistent or recurrent disease, of course, if they are not candidates for surgery or refuse surgery, but the patients need to understand, because now with all these medications, a lot of patients really want medications rather than surgery. But I tell them, and this is coming from me, that I have been part of these studies and I really recommend medical therapy to a lot of patients. The truth is we have nothing that's better than surgery if the surgery works. So at least for the first surgery, I'm trying to convince everybody to go to surgery, especially for Cushing's disease. Now for second surgery, it's becoming more of an issue because what happens is the risk of second surgery are much higher, from CSF leak to hypopit, that's 50%. And then the risk of the advantages are also, even in the best centers, the diseases that are recurring, it's about 50% chances of remissions. So you are left with what I'm going to do. So sometimes I start medications for recurrence, and then, as you've seen in some of the graphs I've shown you, I go back if the patients don't do well or the tumor is progressing or something and recommend repeat surgery. And I have patients now that are 4 years on meds and actually doing great. So I think I'm going to continue this approach, but patients need very, very close follow-up. And then I'm hoping the same that we're moving for acromegaly, we can have better data that for Cushing's we don't have as good, but we're getting there. From all these patients that are coming to us for help, they have persistent disease after surgery, that based on comorbidities, disease characteristics, some biomarkers, we can say you will benefit of this treatment, you'll benefit of this treatment, you this one. So we're not there yet, but I'm hoping that we'll get there soon. And for the fellows, if they're interested, some of these papers are open access. The consensus on Cushing's disease is relatively recent, the JAMA review, and we also have the Nature and for more primary care in Lancet, that's very recent, a review of more Cushing's syndrome rather than Cushing's disease. And with this, I wanted to thank you for inviting me to talk about such a fascinating disease. And you have here, this is Portland. This is the other part of the hospital. This is clinic. So that's how we go between clinic and hospital. This is my hometown in Transylvania, Romania. I'm a vampire, if you didn't know until then. And Kelly told me that you need this event code. So see, Kelly, I did not forget. So I hope you had enough time to write it down, 1283319. And with this, I'm really thanking all of you for listening to me, and I left more time for questions. Thank you.
Thank you, Dr. Fleseriu, for excellent summary of all the information that is up to date. So, so one of the things that I had was, there's certainly a lot of heterogeneity in response, So the question is, what explains that heterogeneity and how do we figure that out?
That would be very good if I would have an answer, and that's a great question. So how I look at this is until we know, and I'm assuming you're not talking about a particular drug, you're talking about drugs in general, correct?
Yeah.
Yeah, so we don't know. And for some of the studies, we actually looked even at PK values, and it's really not clear why for some patients, for example, talking about the heterogeneity, they normalize the urinary free cortisol perfectly, and then they don't normalize their symptoms or the comorbidities. When we looked at some of the analyses for few of the prospective studies, there were patients that actually had more improvement clinically, even if they didn't normalize the UFC. So what you are commenting on is great, but we have nothing. We looked at, and the paper is now published, but I presented it recently in Europe, for example, just to give you some examples for differences in response to oscillogostat, because there we had the data between patients of Asian origins and patients that were not Asians, again, with a culprit of several different populations of Asians that I'm aware of. But the dose needed for control was significantly lower. And we thought it's related to BMI, just because whites have higher BMI, but it wasn't. So it's clearly related to PK and other factors. So this is the only thing that we think of. It's not related to BMI. And I'm sure that the response rate, it's also not just numbers, is how long you had the disease. But do I have a proof to tell you that? No. But I think it's just that some complications and even clinical symptoms are so long and they are at the point of irreversibility. So how I'm thinking in my mind is how we do for acromegaly, that we tell patients for joint pain, forget about it. It's not going to, maybe better, but it's not going to disappear. So I think we should have more data that we don't for Cushing's also to set up the expectation to what's improving and what not improving. In all the clinical trials, we just fish around for all the clinical improvements.
So there's a question here about Cushing's disease diagnosed during or if recurrence suspected during pregnancy.
So you are really hitting me with all the tough questions. So that's very, very hard. And for the fellows, you all know that the CRH activation in pregnancy is significant. So all the numbers will be high. And on top of that, in the blood, the CBG is going to be increased. So the free should be okay. So what I usually look at is if it's recurrence, I'm more worried about, because then the likelihood of being real Cushing's, it's higher versus pseudo Cushing's and just the patient was upset or some other reasons of increased cortisol in addition to the pregnancy. I go by saliva cortisol way more. And then treatment-wise, I do not like to use medical therapy in pregnancy, as we know, though sometimes cabergoline can be an option if the patient is ready and getting to delivery soon, and then we can do surgery. Sometimes we did surgery in second trimester, but the diagnosis has to be really clad. So all the numbers should look the same. Just for mild elevation, I wouldn't do any treatment. And if I'm really not sure, I tell patients, I think you have it. Let's drag our feet and just treat the hypertension. I talk to OBGYN and all that. But the free cortisol, assuming they sleep well, the saliva cortisol seems to be better. And of course, overnight DEX is useless, but it is very hard.
So I just have a follow-up question to my question about pregnancy. If you do you routinely anticoagulate them because they are at a higher risk while you're watching them closely?
Yeah, so that's a very interesting point. I don't routinely do it because in pregnancy I'm panicking, but I always call the OBGYN, and the same thing for patients with cancer. So I had a patient with adrenal cancer now that I said, I think this patient needs to be anticoagulated. So the oncologist said, yeah, but with the chemo are doing, it's really high risk of bleeding and all that. So what do you want me to do? So the same thing is for pregnancy. I usually recommend, but I'm not the final decision because I don't know enough about pregnancy. I barely know enough about the diabetes anymore, but The same thing with the Cushing's disease. If it's a repeat surgery and the ENT was really unhappy the last time, I'm talking to them and say, hey, this patient needs anticoagulation. Also, what's important for pregnancy is the risk of infection if it's severe Cushing. So that's another issue, which medications they can take. And then what we recommend, and you've probably seen in some reviews, and I don't think I mentioned that enough, that we use Bactrim for PGP pneumonia nicely. If we use oscillodoscopy, for example, or other drugs that can prolong treatment, Bactrim can be used. So it has to be something else. So there are a lot of nuances that we have to read. I wrote one of the papers and I had to
Thank you.
Okay, so one of the, now I got to read the question. Sorry, I figured out where it is on Teams. Do dementia-like and psychiatric symptoms need additional pharmacological interventions? So that's a very good question. And the answer is yes. In Europe, because they have better, more holistic medicine, here the insurance half of the time, if even Medicaid doesn't cover for to see psychiatry or counseling. The patients are seen by either a psychologist or psychiatrist if they have a diagnosis of Cushing. So that was my dream from when I came to Portland. But guess what? I can do it because of the insurances. But theoretically, if they really have any psychiatric symptoms, I send everybody for additional pharmacological because to improve it enough, even severe depression, to improve it enough, just with decreasing the cortisol, it's impossible. And after surgery, gets worse because they have withdrawal and they don't feel well, sorry. So they definitely we need more help. And then is there any gender difference with the cognitive symptoms with Cushing? So that's a very good question. We don't have very good data for the cognition per se, but the studies that were done at the brain level seems to be worse in women, but keep in mind that the women are more in the studies. So because it's Cushing's is more in women. So I wouldn't say specifically. What we know though for quality of life is significantly worse in women versus men in the few studies that looked at. And then if you ask me the cause of it, I don't know. We know that for hypopit, for example, and these patients that need multiple treatments and end up having Cushing's and then hypopit on top of that, the woman had even higher mortality in addition to all the other complications. So exactly, is this estrogen related? Is it something else? When we look at our data, for example, for cardiovascular disease and VTE events, that was just VTE, and then we did one with arterial also. Women are more, but we're the majority of the patients, so I don't have a direct answer for that, but seems that is a gender difference, and we definitely have to look more. I try to look at gender differences, for example, in the some of the clinical trial data that I had available when I was a PI, but because it's more women, you can't really look at differences in between them. Sorry, but that's a very good project.
So with the thromboembolic complications, even with post-op, even if you have very mild thing, would you still worry about it, or is there anything?
Yeah, so that's a very good question. The truth is that even mild disease, immediately post-op, if they are in remission, the answer is yes, they are at increased risk. Now, we are able to anticoagulate everybody? Because I don't want to put them on warfarin. Lovenox still is not covered by all the insurances, but at least for a week to 2 weeks, I'm trying, unless they have contraindication, to treat.
Because in the other situation where there is this is adrenal Cushing's, where you have autonomous adrenal function.
Yeah.
Where you think that maybe you shouldn't anticoagulate them because that's a large number, but their cortisols are not that high.
Yeah, so I thought you were asking more about Cushing's disease, for prolonged Cushing. So yes, adrenal patients, I very young. Also, they have, most of them have milder Cushing's. Yeah, so the adrenal, you're correct. the laparoscopic surgery, they go home the next day. And usually they don't have the clinical characteristics that are so severe. Though I had an adrenal Cushing that I ended up anticoagulating, and then patient still had a PE, but I think it was more complicated than that. Maybe we should do more in adrenals, but I usually don't do it. I thought you're referring to the Cushing's disease or ectopic. Sorry.
Can I ask you your view on the relative safety and efficacy of levoconazole versus ketoconazole?
So that's very interesting. And as you've seen, I showed you the data that we had on levo-keto. We have no studies looking at keto versus levo-keto, zero. In my experience, because the levo-keto we looked prospectively, I feel more comfortable because I know exactly when to check and what to check. If you look retrospectively at the data of safety between levo, for liver, for example, between levo and keto, seems that it's a little bit better for levo-keto, but I don't know because you're comparing apples and oranges. But at least if I have to use an adrenal thyrogenesis inhibitor and I'm deciding on either keto or levo-keto, levo is approved. We have warnings. I know exactly what to measure, but I can comment on something that I really don't know. I would have liked to do a study to compare, but to get funding to do a study like that would be impossible, as you can imagine. Why were you asking? So what is your specific question in safety? You said safety and efficacy.
Well, I suspect there's a difference in cost.
Yes, for some of the insurances, they get some support. But cost to society, definitely. Keto, it's not very cheap either, but yes, levo-keto is more expensive. However, what I'm thinking is that if the patient starts keto, if they were on keto before, I left them on. But if now I want to start keto, when we have a drug that's approved, if the patient develop liver dysfunction and it's idiosyncratic, it's different when you are using an off-label drug versus a on-label drug. You know what I mean? But I'm not saying one is better than the other. And I'm not commenting on any of the cost of the drugs I've shown you. I kept on the science because all of them are expensive and significantly more expensive than they should be after a while. I understand that we need to look at the clinical trials and all these costs, but at some point they should be generic and move on. But that's my opinion. But
I have another question, Maria.
yeah.
So I don't know if the fellows discussed already. So if it is repetition.
No, well, I meet after that.
Oh.
Yeah. Nice.
So the question is related to, if you had mentioned it in your talk, this is a patient who has had 2 surgeries and radiotherapy and now has the recurrent tumor, but clinically, biochemically, no recurrence. But of course, symptoms, it's hard to say. So those patients with the tumor and the surgeons are hesitant, or the surgeon is hesitant because it's already been operated twice and has had radiation.
Usually they're hesitant more because they don't like to go after radiation because all of the tissue is mushy.
Yeah.
I've seen it. Yeah. I completely agree. Yeah.
So in those situations, how frequently do you monitor, or do you just assume that it's still an active tumor even though you don't see biochemical evidence yet? Do you just go ahead and start some medication? So I struggle with that because many of the patients, many times the weight gain is there, and it's hard to say because some patients do eat terrible and have severe metabolic syndrome also. And then if the other data is missing for biochemical recurrence, then how do you approach that?
Yeah, so that's a very good question and clearly the toughest one. If the tumor is really growing after radiation, I'm worried because yes, it can become a silent one, but it's even worse than active Cushing's if you look for progression of the disease. if the tumor is real growth, not because the MRI was done somewhere and we did another MRI, looks like it's growing. If it's real growth, then I do enough biochemical testing that at some point I figure out. So I have patients that I do 10 saliva cortisol and all that. So if the saliva cortisol, for example, is abnormal and the tumor is growing, then I'm starting treatment. And I do low dose pasireotide and cabergoline. The role of cabergoline for Cushing's in itself, it's minimal. For tumor, I'm not sure, but for Nelson in older times, they were using it, even valproate combination. So the disadvantages are much lower at this point. I don't like to use it because of the impulse control disorders in some patients, but otherwise, with really growing tumor, I'm talking about treatment. And if you look at the data, because this is what you are describing, again, even if it's silent, it's almost something that you have to treat the tumor regardless of Cushing's in itself. And there were some data for pasireotide. Not everybody will respond. This is exactly what you asked me earlier. We don't know whether they respond or not. For pasireotide, there are some markers that the German group, and I talked to Martin last week, they're looking at, and for USP8, they were hoping it's going to be a predictor of response, but it's not. So hopefully we get more markers there. So a patient like this, becoming silent ACTH, I've seen it enough, but also in the future is with even more aggressive tumor is very worrisome.
Worrisome. Okay, thank you. And pasireotide is so hard to get approved in such patients where, not everything fits the thing, especially if it's a Medicaid and which this patient is. So
yeah,
do you have any tricks for that?
But usually I pick up the phone and I ask them, what else do you want me to do for this patient? Because if you just send the paperwork, it's a no.
Yeah, it's
but
a lost
on the phone, when you talk to somebody, I said, okay, fine. The patient had surgery, the patient had radiation. I have nothing else, and the tumor is growing. Tell me, and I will do exactly what you tell me to do. Tell me what should I do next.
Okay.
And then they approve it.
Okay, thank you.
Sometimes I send them also the guidelines, but this is not the case. But sometimes if I want something approved, I send them the guidelines.
With your name on it, right? So it's easier.
Yeah, that's true. Sorry, even without my name on it.
There's usually some orthopedic surgeon who is reviewing your the case.
Yeah, so that depends, but it's funny. I had one for acromegaly that was the most disconcerting that I had with an insurance. And the guy was very, very nice. It was a chiropractor approving surgery for acromegaly that was denied. So barely knew what acromegaly is, and the patient had a tumor, but they said that because the tumor is not big enough, it was like didn't make any sense. So on the phone, he's like, I'm a chiropractor. I believe you, but these are my criteria. I'm like, I need to talk to somebody else. But then I got it approved. But that was funny, So that's when I found out, this was years ago. That's when I found out that actually you're not talking to somebody that has the same specialties. Because this was new to me, coming to US in residency and fellowship, I didn't look at that. And then when I started to practice, I thought you're talking to specialists and all that. So, yeah.
Yeah. Thank you so much.
You're welcome. Any other questions? Because I have to meet with the fellows in,
Shortly.
I think.
Yeah.
Kelly, what did you say?
You're meeting with them now. Yeah. Then.
Okay.
Okay.
Did you see this? Did you see my cup?
Yes.
You need it a lot for Cushing's patients.
Definitely. So any other questions? You have my email if you want, but anything else that I know the answer, because some of these really nobody knows.
Yeah, that's very informative. Thank you so much.
Thank you very much.